Welcome to this yet another lecture on the topographic anatomy of the lower limb. In this particular session, we are going to look at topographic anatomy of the knee joint complex. We call it a complex because, as we are going to see shortly, it consists of multiple joints actually. If you do remember, in our series of topographic anatomy of the lower limb, we have quite several lectures that are outlined. And now we are on this particular fourth one that we're doing in this particular session. Just a background before we delve into the knee joint itself. We know that the body has multiple systems, and one of those is the articular system. When we talk about articular system, we're talking about a system of the body that is concerned with the joints. And generally, this articular system is part of a bigger supersystem, which we call the locomotor supersystem, that consists of the articular system, the muscular system, and the skeletal system. But what is a joint? Simply put, it's a junction between two or more bones. And the purpose of joints is generally to allow movements to occur. So different joints will have different degrees of mobility. And so joints allow movement. But something else that also happens is that by the presence of joints, we can now have ends of bones on which growth usually occurs. So growth occurs towards the ends of bones, and it can only be an end of a bone if a joint is next there, so to speak, or it's an external thing. So generally, we can say that joints also allow growth in that sense. Now, a joint can be considered to be simple or compound. We call a joint simple if there are just two bones articulating that particular joint. And we call a joint compound if there are more than two bones that are articulating in that particular joint. As you're going to see, knee joint has multiple bones, and so it will be an example of a compound joint. We can also classify joints based on the structure that form them. What is joining these two bones or these multiple bones? So in this classification, we have what we call fibrous joints, the ones which are joined by fibrous tissue. We have cartilaginous joints, where bones are joined by cartilage, or at least some types of cartilage. And you have synovial joints, which the knee joint is actually an example. A synovial joint is a joint that has a cavity that is filled with synovial fluid. And so synovial joints usually allow a vast degree of movement compared to the other two types of joints. As a matter of fact, the knee joint is the largest synovial joint in the body. Now, when we're describing synovial joints, there's some basic concepts, or rather subtitles, that it would be nice to bring out if you want to comprehensively describe the topographical anatomy of any synovial joint. And perhaps I'll just lay down that foundation here. Then now, as we go along in this specific lecture, we'll now fill the gaps for the knee joint. One of them is the location. Simply put, we just want to know where is that joint found, which bones are involved in the articulation in that joint. That's straightforward. The other thing we want to know about a synovial joint is its classification. We want to classify synovial joints based on the configuration of the articulating surfaces. Is it ball and socket? Is it condylar? Is it planar? Is it saddle? There are many configurations that we can talk about. But we also want to classify a synovial joint based on the number of axes of movement of that particular joint. Is it a uniaxial joint? Is it biaxial? Is it multi-axial joint? After that, we talk about the articulating surfaces. This is more of a detailed description of the parts of the bones that actually make contact in that particular joint. And remember, for synovial joints, the articulating surfaces are lined by hyaline cartilage, a unique type of cartilage that specifically we call articular cartilage. So we want to describe the parts of the bone that are actually lined by this articular cartilage so that we call it an articulating surface. Very important. Sometimes this may not just be limited to bones, could be also other structures, like we have situations where some ligaments are also making contact, and in that case, the ligament also becomes an articular structure. Then an important aspect is the stability factors. What parameters in this joint prevent it from dislocating or prevent it from performing some excess movement that are not required or which are unnecessary? We generally classify stability factors into static and dynamic, where the static ones would be anything to do with either bone configuration. Is it an issue of the capsule modification, or is it some specific ligaments within this particular joint? Those are static, they do not change. The dynamic ones would be to do with the muscles and their associated tendons. So they also contribute to stability. They're still key stability factors of a joint. Generally speaking, when we're talking about stability factor of a joint, of a synovial joint, it will be important to then mention which of these parameters is the main stability factor. Yes, in as much as we have multiple of them, but which one is a major contributor to the stability? That if it is compromised, then the stability of that joint significantly reduces. Relation anatomy is an important aspect of topographic anatomy in general, not just related to joints, but in general. Topographic anatomy is an important, or rather relation anatomy is an important aspect because we want to know what is next to this particular structure. The implication here is that that will inform how we gonna approach this particular region during operations, or if there is an injury, which structures are actually at risk, and how then can we make diagnosis of some of these injuries based on some dislocation that we've seen or some fractures that we've seen. So it's important to understand the relation anatomy of any organ in the body, and joints are not excluded. Neurovascular supply of a joint will be more about the arterial blood supply and the innervation. The innervation here is predominantly the sensory innervation to the joint structures, mainly the capsule or the ligaments around the joint, or some interarticular structures if present. We talk about that. Mobility, we look at how does this joint move? What are the degrees of movement that it can accommodate? What's the range of these movements? Which kind of movements can be performed? There's some joints, especially the multi-axial ones, that can perform all directions of movement, but there's some that are limited directions of movement. So it's important to then highlight in the joint you're talking about which movements are acceptable. And when you're discussing movements, it's important to then also highlight the key muscles which are involved in this particular movement. Last but not least is the clinical relevance. Highlighting some anatomical concepts that explain some clinical scenarios is very important, or some anatomical concepts that help in some clinical interventions. It's very important. Now, in the description that we're going to take in this session, I may not single that out at the end as it is in this particular one. I highlighted here so that we do not forget that's an important thing. But the easiest way to talk about clinical relevance is to incorporate it in various segments that whatever we're talking about actually applies. So I'll take that approach as well. I'll highlight some clinical aspects in specific parts that we're going to talk about in number 1 to number 7. So with that introduction and with that outline, we can now start with our first agenda, the anatomical location of the knee joint. This is straightforward. We all know where our knee is, between the thigh and the leg. So basically, that's the knee joint. And in this radiograph, we also appreciate the bones that participate in the articulation that we're calling knee joint. So distal femur, proximal tibia, and the patella. Primarily those three. Some people consider this other joint here between tibia and fibula proximally to be part of the knee joint complex. A number of authorities do not consider it there. Occasionally, that joint may also communicate with the knee joint, actually, and perhaps that's why some people consider it to be part of it. I will not consider it here because I want to tailor this to knee joint actually proper. And so I'll not consider it there, but remember that it's also an important joint to talk about. Maybe we'll talk about it in our next series when we're going to talk about the anatomy of the leg. But that's the proximal tibiofibular joint, which is a synovial planar joint. All right, so let's focus on the knee joint. In this particular image, we see it's an MRI image of the knee joint in coronal section, and we see the bones that form the knee joint. So here we have on the upper part, we have the femur with its condyles there, and we have tibia down here. So basically, that's the knee joint. This is coronal section of the knee joint. It's an MRI image. The second image is a sagittal image, which means that we're looking now at the knee joint from a lateral view. Again, we see the three bones that participate in the articulation we're calling knee. Let's wait for it to come. We can see now this is the tibia, and that is the femur, and that's the patella. So basically, that's the knee joint as well. All right, we can now go to our next agenda, which is the classification of the knee joint. How do we classify the knee joint? Overall, we can say that the knee joint is compound synovial joints. I think we've already underscored that. We call it compound because there are three bones, basically, which we're talking about. Now, maybe just something more to elaborate on this compound nature. Some people consider the knee joint to consist of three distinct and partially separate compartments. We have this compartment here between the patella and the femur. So we call that the patellofemoral joints. And then we have this compartment and that compartment. So these are the tibiofemoral joints. So we have the medial one, and the lateral one. You may wonder how I picked this to be lateral. It's easy. You just see the location of the fibula. Then you know that there's a lateral one, and that's the medial one. So this is the lateral tibiofibular articulation. Sorry, tibiofemoral articulation, and this is the medial tibiofemoral articulation. So let me just repeat that. Three separate compartments, or rather three compartments which are partially separated. The medial and the lateral tibiofibular articulations, these two, and then you have the patellofemoral articulation. Based on the configuration of the articulating surfaces, we consider the tibiofemoral articulation to be of a condylar variety because we have the femoral condyles articulating the tibial condyles. Based on this other joint here, we look at the patellofemoral articulation. We consider it a sellar joint or a saddle variety because of the nature of the articulating surfaces there. We are going to see that the articulating surfaces there are convex in one direction and concave in another, almost 90 degrees direction. And that is what constitutes a sellar variety. So this is the condylar variety, the medial and lateral tibiofemoral articulation. And then there's a sellar variety, the patellofemoral articulation. Based on the number of axes of movement of this joint, the knee joint is predominantly a hinge joint. We like calling it a modified hinge joint because the axis of flexion and extension at the knee tend to translate at different degrees of flexion and extension. But either way, it's predominantly hinge, uniaxial type of joint. However, we know that when the knee is in some flexion, perhaps mid-flexion, that the knee can accommodate some degree of rotation. Particularly the tibiofemoral articulation accommodates some degree of tibial rotation when the knee is in some flexion. And so for that reason, we can also consider that to be another axis, although not very active, not very often, but yes, it's another axis. With that in mind, some people may then consider the knee joint to be a biaxial type of joint. Remember, the axis of rotation is very limited, best seen when the joint is in mid-flexion, and the degree of rotation is not that much as well. And that is why we prefer to call it predominantly a hinge joint, or rather predominantly uniaxial type of joint. Now let's go to the description of the articulating surfaces, and we'll start with the articulating structure. We'll start with the patella itself. Now, the patella participates in the articulation at the knee. It's the largest sesamoid bone in the body, by the way. This bone is embedded within the tendon of the quadriceps. Remember that the quadriceps femoris, from our description, the thigh arises from up here, and so attaches to the patella, and then we'll have a patellar tendon that extends all the way to the tibial tuberosity. So we can say that the patellar bone is embedded within the quadriceps tendon. And why is this important? In this image, we can see that patella is embedded within the quadriceps tendon. So proximally, you have that quadriceps tendon, then you have the patella. Then we can call this patellar tendon as an extension of the quadriceps tendon. Some people call it ligamentum patella, in the understanding that it connects two bones, so therefore it qualifies to be called a ligament. Otherwise, we can still call it patellar tendon in the understanding that patella is actually a sesamoid bone in as much as that big, And so it is along the course of a tendon, not a ligament. What are the key functions of the patella? The patella protects the quadriceps tendon from its wear and tear. You can imagine if the quadriceps tendon would be rubbing against the knee, or other femoral condyle and tibial condyles every time you're flexing and extending, there'll be a lot of wear and tear on this quadriceps tendon. So it protects the quadriceps tendon against wear and tear. Well, we can also consider that it also protects the anterior aspect of the knee. If in full flexion, the knee would be that exposed, it could be perhaps predisposed to injury. So the patella is a key thing in just protecting. You can imagine if you were to kneel down, but you didn't have patella, perhaps you'll be subjecting your knee to some injury. So the patella protects the anterior knee in that sense. The patella also increases the mechanical advantage for extension function. What does that mean? With the press on the patella, the quadriceps tendon is slightly tilted anterior away from the transverse axis of flexion and extension of the knee. In many words, we have increased the distance from the pivot of flexion and extension. If you increase the effort distance from physics, we know that we increase the mechanical advantage. Maybe if I was to again say that in a simpler term, with the press of the patella, we'll require less energy to perform an extension role that would have otherwise required more energy to perform if we did not have the patella. The other role of the patella is that it realigns the oblique pull of the quadriceps unit. Now, for you to understand that, maybe this image will help us. From our previous conversation in the anatomy of the thigh and hip, we understood that the femur is not straight. It is actually inclined. The tibia itself, however, tends to be a bit straight. Now, what does that mean? It means that the long axis of the femur and the long axis of the tibia are not in a straight line. If the long axis of the femur is not vertical, then it means that the resultant pull of the quadriceps unit is also not vertical because the femur itself is inclined and the quadriceps are on the femur. So we can use this imaginary line there to represent not necessarily the shaft of femur, but the axis of pull of the quadriceps. This is an imaginary line that extends from the anterior superior leg spine to the center of the patella. It corresponds with the axis of pull, axis of action, the vector path of the quadriceps pull. We want this oblique pull of the quadriceps to be straight on the tibia. And so the patella actually realigns that oblique pull. You know how pulleys work. It acts as a pulley to actually realign the oblique pull. Great. This angulation there, we are going to talk about it again shortly. We call it the Q angle. The Q angle is greater in female than in males. And the reason why that is so is because the females have a wider pelvis, which means that femoral inclination is greater in female than in males. Now, let's revert to the patella itself in terms of its structure. The anterior surface of the patella is usually subcutaneous, so just applied to skin, and it's rough, as you can see in this particular image, with the apex pointing down and the base is up. The anterior surface is rough, which means non-articular. But the posterior surface is the one that is articular, so it's smooth And this posterior surface is the one that is lined by articular hyaline cartilage, by far the thickest articular cartilage in the body. So it is usually applied in this surface of the patella. There's a vertical ridge on this particular surface that divides the patella into two facets. One larger one, the larger one is lateral, and the medial one is smaller. So you have the medial facet that articulates with the surface on the medial condyle of femur. And then we have the lateral facet that also articulates with the surface on the lateral condyle of femur. Now this image shows us the knee joint in axial section. So this is the patella, and this is the femur, the femoral condyles. What I want us to notice in this particular image, this is the level of now tibia. Now we come back to the femoral condyles. What I want us to see is the thickness of the cartilage of the patella. This is the articular cartilage of the patella, very thick, the thickest actually articular cartilage in the body is found at that point. This is the patellar bone. This is its articular cartilage. This is the articular cartilage for the femur, particularly that patellar surface. So you see now this is the lateral condyle that articulate the lateral facets. This is the medial condyle that articulate the medial facets. All right, so these are the images. I've already told you that the patella has a base which is superior and an apex that is pointed inferiorly. Anterior surface is rough and posterior surface is smooth. One of the things that we expect any student of anatomy to know, well, depending on the level of training, is how to sight the patella. It's a simple but can be tricky. So we want to know whether you can determine whether a patella is from the right side or the left side of the body. That is what it simply means to sight a bone. Just want to know whether it's from the right or the left side of the body. Now for patella, we've already mentioned that the apex points downwards, the smooth surface is posterior, the rough part is anterior. The lateral facet is larger than the medial facet. So you put those into consideration and you sight the bone. The simplest way of doing it is just to place the patella on the table on a flat surface with the apex pointing away from you and the articulating surface being on the table or on that flat surface. So the patella will then lie or fall on one side. It will only fall on the side with the larger facet, which means the lateral facet. So if this patella is from the right of the body, then it will be on the right. It will fall to the right. And if it's on the left side, from the left side of the body, then it will fall to the left. So the side that the patella falls to is its actual side. It's a simpler way of sighting the patella. Great. Something clinical to mention about patella. Two things that I want to mention. One is that the patella is prone to dislocation because of that Q angle that we talked about, but I'll highlight that more when we discuss this patellar stability, when we discuss the stability factors. The other thing I want to talk about is the ossification of the patella and how that manifests later. So the patella ossifies from multiple centers, and these centers may not fully fuse. Most of the time we may have, or rather sometimes, we may have one center not having fused the rest of the larger part. This may easily confuse with a fracture. We call it a bipartite patella. You can also have a tripartite patella if there are three multiple parts. But the bipartite one is more common than the tripartite one. The embryological base is the same in terms of the concept of its how it occurs the same. And so we can just talk about the bipartite patella. This is an example for bipartite patella. So this is the different individual from these two, but these two are from the same individual. We can see something there, which you can see there nicely. May confuse with a fracture, but that is basically a bipartite patella. This is a different individual. You can see that separation between this and the main mass. Having talked about the patella, we can now talk about the femoral condyle. So this is the other articulating structure of the knee. Femoral condyles are those expanded, rounded ends of the distal femur. We have medial and lateral femoral condyle. So these are the condyles. The space between them is called the intercondylar notch. From posterior, so this is from posterior aspect, the notch is more prominent, but from the anterior aspect, the notch is not very prominent, but we can still see the patellar surface there. So this is the lateral condyle and this is the medial condyle. Take note that these distal parts of the femur are the ones that articulate with the patella, these points, and tibia on the inferior side. So this is the part that articulates with the tibia, and this is the part that articulates the patella. Look at the articulating surface, that part that's lined by hyaline cartilage, and we notice that almost forms like an inverted U kind of a shape or appearance. The patellar surface is concave transversely like that, and convex anteroposteriorly like that. And that is why the patellofemoral articulation is therefore considered a sellar joint or a saddle type of joint, because it will be convex this way but concave that way. And the patellar surface also corresponds to that. It conforms to that particular configuration. These are the parts that articulate with the proximal tibia. So again, we just call them the medial condyle and the lateral condyle. So again, this is the lateral condyle and that's the medial condyle. The tibial surfaces are convex on either direction. So they're convex this way as well as that way. Even this one convex this way as well as that way. But the medial and the lateral femoral condyle vary in some parameters. And we often use this to even be able to determine whether this femur is from the right side or the left side. Let me use this image to highlight for you some of the differences. So we are looking at the inferior femur. This is the lateral femoral condyle, and this is the medial femoral condyle. One thing we note is that the lateral femoral condyle has an anterior projection that's more prominent than the medial femoral condyle. We call this the buttress. So the lateral femoral condyle buttress is more prominent than the medial femoral condyle buttress. Remember, the buttress is for the surface of the patella. So if you are to put an imaginary line here somewhere there to eliminate the patellar surface from the picture, maybe put it somewhere there, to eliminate the patellar articulating surface from the picture and remain with the others, we can have even more description about the difference between the medial and the lateral femoral condyle. Let's compare which one is more straight. this one will appear to be more straight, the lateral one, compared to this one. So the medial femoral condyle articulating surface is more curved. And the lateral femoral articulating surface is more straight. We can also compare this one. The lateral femoral condylar articulating surface is wider compared to the medial one, which is narrower. The last one will require that you remember what I told you, that we can remove the patellar articulating surface from the picture. Then I'll measure the anteroposterior distance of the remaining segments. If we do that, then you'll agree with me that the middle one is longer than the lateral one. So the medial femoral condylar articulating surface for the tibia is longer compared to the lateral femoral condylar articulating surface for the tibia. So we are looking at this anteroposterior distance, and we note that it's shorter on the lateral condyle than on the medial condyle. Remember, you have to eliminate the issue of the prominent buttress first from the picture before you make that conclusion. So with that in mind, I want to look at this distal femur again and think about which side this bone arises from. Is this from the right side or from the left side? Understand that we're looking at the distal part, so we've already oriented the femur in terms of its proximal distal orientation. We also know that this side is anterior and this side is posterior. Because the notch is more prominent posteriorly, the patellar surface is definitely anterior. And now I've told you that you say you distinguish the medial from the lateral. This is lateral and this is medial based on the difference I've just told you. So having oriented the bone in those three axes, I'm hoping you have concluded that this is left femur. All right, this is also another image of left femur. You can see how the lateral femoral condylar buttress is more prominent than the medial femoral condylar buttress. We can also appreciate the curved nature of the medial condyle compared to the relatively straight nature of the femoral condyle. Note that the notch is more posterior. This is an image of the knee joint MRI, and we are seeing the patella, we are seeing femur. At this level, we are now on the upper part, it's a single bone, so that's femoral shaft. Coming down to the joint, that's patella, this is femur, so the condyles, you can see them there. And now we are at the tibial side, and now we can see tibia and fibula there. Now, maybe it ends there. I want to replay it again so that I want you to see something about the femoral articulating surfaces compared to the tibial articulating surfaces. Okay, so this is the femoral articulating surface. I want you to look at that distance. Compare that with the tibial articulating surface. Something important I want you to pick. Okay, so that's femoral, and now we move to tibial surface. So this is a tibial surface. One thing I want to pick is that when you look at the anteroposterior distance for the femur and compare that with anteroposterior distance for the tibia, that the femoral anteroposterior distances are longer than the tibial anteroposterior articulating surfaces. Something very important to remember as we go to talk about the mechanisms of movements at the knee. All right. Now let's talk about the third articulating structure. That's the tibial plateau. We know that the proximal tibia is the one that participates in the articulation at the knee. Some key structures to highlight about the proximal tibia is the tibial condyles. So we have the medial and the lateral femoral condyles. We also have what we call the intercondylar area. So this region between the medial and lateral condyles is what we call the intercondylar area. And then we have the tibial tuberosity. The tibial tuberosity is slightly inferior compared to this other two that we've already mentioned. Tibial tuberosity is anterior and is a point of insertion of the patellar tendon. So again, I'd want us to be able to side tibia based on some anatomy that we're going to describe, just as what we've done for femur. Similar concept, so bear in mind as we discuss the difference between the medial and the lateral tibial condyle, you should be able to then know whether this tibia is from the right side or from the left side. So what is tibial plateau? Tibial plateau is the top surface of tibia. That part that forms the tibiofemoral articulation is what we're calling the tibial plateau. So this top surface. So that means that we eliminate tibial tuberosity from the picture, and whatever we're remaining with is what we call the tibial plateau. The two condyles are separated by this region that is non-articular. And that is why we're considering the tibiofemoral articulations to be two compartments, because we can see here that there are actually two different compartments. The intercondylar area is non-articular, but this area is divided into three parts. So you have the anterior intercondylar area, the posterior intercondylar area, and the intercondylar eminence and elevation. On the eminence, there are two spines or tubercles, the medial and the lateral intercondylar tubercles or spines. All right, so this shows you the tibial plateau, the condyles, and the intercondylar area. So this is quite projected upwards because of the presence of the eminence. This shows you again the area. So we have the anterior intercondylar area, the posterior intercondylar area, and the eminence. And the eminence has those tubercles. Generally, if you look at the articulating surface, the medial one usually tend to be more ovoid, and the lateral one is more circular. Maybe a better image would be this one. So the medial tibial articulating surface is more ovoid compared to the lateral one that is more circular. I had already mentioned to you that if you look at this distance, anteroposterior distance for the tibia, and compare it with the anteroposterior distance for the femur, that the femoral anteroposterior distance is longer than the tibial anteroposterior distance for the corresponding condyle. So you compare this with the lateral femoral condyle, and either way, even if we say that the lateral femoral condyle is shorter than the medial one, the lateral femoral condyle articular surface is still longer than the lateral tibial articulating surface. And same concept applies to the medial articulating structures. The medial tibial articulating surface has a shorter anteroposterior distance compared to the medial femoral anteroposterior articulating surface. And those are important in understanding the mechanisms of flexion and extension of the knee joints. All right, now being very flat, not very stable, the articulating surfaces for the tibia are covered or lined by menisci. So there's something called meniscus that covers the top parts. We have the lateral meniscus that covers the lateral tibial condyle, and you have the medial meniscus covering the medial tibial condyle as well. So basically the menisci cover the tibial plateau. They are interposed between the tibia and the femur. Okay, so this image captures what I have already told you about the anteroposterior distances, but we can still have a look at it. So this is the tibial side, very short distances. It's going slightly down, so we are seeing the tibial tuberosity there with the patellar tendon, that dark signal. So this is the tibial plateau. And now on the femoral side, look at those distances, quite longer than the corresponding tibial ones. That's what I wanted to capture in that particular image. All right, now we can talk about the stability factor. Now, knee stability is a big thing. Let's discuss it thoroughly as well. We'll start with the static stability factors, then we'll discuss the dynamic stability factors. The static ones are very key. Just like any other joint, I told you that static factors can either be bony factors, ligamentous factors, or capsular factors. Let's start with the bony factor. When we talk about bony factor, we're just looking at the congruency of bony articulation. How congruent are the bones articulating at the knee? Remember, there is the patellofemoral articulation and the tibiofemoral articulation. The patellofemoral articulation has actually good congruency. This is to mean that the patella fits nicely onto the femoral surface, or rather the articulating surface for the femur. So the patella is configured to fit nicely in that space, as you can see here. So that's a good articulation, which means it offers good stability as a bony factor. Something important to note, however, we mentioned earlier that there's a Q angle that makes then the pull of the quadriceps not to be very vertical. It's slightly angulated laterally. Now, because of that resultant lateral force that is pulling the patella, in as much as pulling upward, it's also pulling laterally a bit because of the angulation of the femur. This tends to make the patella to have a natural predisposition to be dislocated laterally. In this image, you can see this is the location of the patella. I can use this one. So this is the location of the patella. If the quadriceps pulls that way, the resultant force will also pull the patella that way. And so there's a natural predisposition for the patella to be dislocated laterally. Now, that does not often happen because of the prominent femoral condylar buttress. So this buttress here is more prominent than the medial one. And so it stops the patella from being dislocated laterally. That's a stability factor. In this image, we can see that. So the oblique pull of the quadriceps, it will pull in that direction. So it may also displace the patella laterally. And so we have to prevent the patella from dislocating. This image shows you an individual with a dislocated patella. So this is a fibula, this is tibia, this is femur, this is the patella. So ideally the patella should be somewhere here, but now it's here. So we can see it's dislocated laterally because it has gone to the side of the fibula. Now, there's some things that actually prevent the patella from being dislocated laterally. One of them is what we've mentioned. The lateral femoral condylar buttress is an important stability factor for the patella. So it stops the patella from being pushed in that direction. There are other factors which will also apply, but we'll talk about them in their respective sides. There is what we call the medial patellar retinaculum. So these are ligamentous structures on this side that anchor the patella on the medial aspect, so preventing it from moving that direction. And we also have vastus medialis obliquus, abbreviated VMO. So these are the lower fibers of vastus medialis muscle. They insert onto the patella from an oblique view. So when the vastus medialis contract, or rather when the quadriceps unit contract, these muscles also contract. The resultant force will pull the patella medially as opposed to laterally. Very important stability mechanisms for the patella. Take note that these two are not part of bone congruency. I've just chosen to highlight this here so that we have a consolidated story about patellar stability. Now let's talk about the bone congruency with regard to tibiofemoral articulation. So the tibiofemoral articulation is not congruent. We know that the tibial plateau is relatively flat. The intercondylar eminence is just a slight elevation. And so the tibiofemoral articulation is not congruent. As a matter of fact, the anteroposterior ones are even very unstable. So the only one that we can say that some degree of stability, transverse stability, is because of the presence of the intercondylar eminence. The transverse stability may be there, but the anteroposterior stability is not there. This incongruent tibial plateau is, however, made congruent by the presence of the knee menisci. And so this is the best time then to talk about the knee menisci. I'd already shown you how they look like. So these are the menisci of the knee. We have the lateral meniscus there and the medial meniscus there. Let's talk about the knee menisci. So knee menisci are crescenteric structures made of fibrocartilage tissue, and they cover more than half of the tibial plateau. We are going to see that this one covers close to 80% of the tibial plateau, and this one covers close to 60% of the tibial plateau. Now, the menisci have horns and bodies. So this is the body, these are the horns. Each meniscus has an anterior horn and a posterior horn. Anterior horn and a posterior horn. The horns are attached to the intercondylar areas, as you can see in this particular image. So these are the horns which are attached to the intercondylar area. Peripherally, the menisci tend to be thick and attached to the capsule. So this is the peripheral aspect of the meniscus compared to the central aspect of the meniscus. So this peripheral aspect is thicker. If you look at that from a vertical view, the superior inferior distance is much longer because the menisci are wedge-shaped in section. So the peripheral aspect is thicker and attached to the capsule. The central parts are thin and on the inside and usually avascular. Now, let me mention why I'm insisting on that concept. From a clinical point of view, this peripheral part is thicker and also attaching to the capsule, which means that this peripheral part receives good nutrition from the vascular supply of the capsule. But the central part, which is thin, is not receiving good nutrition. It is still receiving nutrition, but the nutrients to it are from the synovial fluid. So the nutrients in the synovial fluid are the one that reaches there. That means that it does not have blood vessels, but also means that it's not well nourished, so to speak. We'll come into the clinical implication of that shortly. What are the key functions of the menisci? People may approach this in different ways and classify the functions differently. But whichever way you approach it, as long as you capture the key functions, I think that's good enough if you understand the concept. So one of the key functions of the knee menisci is that they deepen the tibial articulating surface. By deepening the tibial articulating surface, they increase the congruency of articulation. So the femur may not just slip anteriorly and posteriorly easily like that, because now there's some degree of curvature. There's some concavity that the condyles of femur will now be resting on. So that improves congruency. It's a stability mechanism. That shows you what I mean. So this is now curved. This is also curved, as opposed to when they're not there, where those surfaces were just relatively flat. The other function is that the menisci are important for absorbing shock and also for distributing load. Let me show you what that means. So let's look at this one without menisci. These are the menisci, these are without menisci. If the meniscus are not there, we can see that femur will come and the force of femur will be concentrated on a very small region on the tibial plateau. So imagine the whole weight of the body being concentrated on just a very small area on the tibial plateau. Because remember that the condyle is rounded. So it will not be that all the surface of femur will be landing on all the surface of tibia. No. Just a small point of femur landing on a small point on the tibia. So that will concentrate the force onto one point. But with the presence of the menisci, the weight can now go transmitted through the menisci and be distributed on a larger surface area. So that absorbs shock. First, that we're now not crushing the articular cartilage of the tibia. Not surprising then from a clinical angle that if somebody does not have the menisci for one reason or another, their joint is predisposed to a lot of degenerative diseases very fast. But because of the presence of the menisci, the cartilage of the joint can be preserved for some time. If you look at the load distribution aspect, I think I've already told you that because of that, the load is now distributed over a wider surface area, and so we are not degenerating the cartilage so fast. Now, you also need to think about it from a physics point of view. If you put some solid structures within a glass of water, the level of water will rise. Well, I'm assuming you understand that these solid structures are heavier, so they'll sink. So the levels of water will rise. Similar concept here. By putting these solid structures within the knee joint cavity, the synovial fluid is now spread out. And this distribution of the synovial fluid is important for lubrication of the joint as well as for nutrition, because we've seen that this fluid is important for nutrition of the surrounding structures. And so some people may put this in a different way. They may say that the menisci are important for nutrition and lubrication. That is what they mean. It's because they spread the synovial fluid that will do that. Important also to note is that the menisci have sensory nerve endings, especially their horns. So the horns of the menisci have a lot of nerve concentration, and these nerves are important in sensing pain, but also in sensing position. Proprioception is a sense of position. So we have nerve endings that have proprioceptive information from these structures. It will tell the individual where the joint is, and this informs the degrees of movement. So these are the key functions of the knee menisci. Let's say something clinical about the menisci from a point of the blood supply that I alluded to earlier. I mentioned that the peripheral aspects of the menisci are thicker and make contact with the capsule of the joints. And that means that the blood vessel that supply the capsule can supply the peripheral parts of the capsule easily. So those regions are red, quote unquote. As you can see in this other image. The central aspects, however, are quite away from those blood vessels. And therefore, these central zones only rely on diffusion of nutrients from the synovial fluid. So this central zone is basically white. You can see what I meant by the central being thin and the peripheral being thick. So if somebody was to have a meniscal tear, a tear involving the peripheral zone will definitely bleed. So it would be a red tear. But a tear involving the central zone may not show bleeding as much because it's a vascular. So it would be a white tear. The implications of this tear is that a white tear, in as much as it may not bleed, so to speak, it doesn't heal faster. It takes long to heal. But the peripheral zone, which have red tears, can actually heal faster because of good nutrition. All right, let's talk about key differences between the medial and the lateral meniscus. Starting with their shape. So the medial meniscus is the one that is more crescenteric. It's more C-shaped. The lateral meniscus is nearly circular, almost almost O-shaped. We can also compare the size of the menisci. The anteroposterior distance of the medial meniscus is longer compared to the anteroposterior distance of the lateral meniscus. However, the thickness of the medial meniscus is not as much as the thickness of the lateral meniscus. So the lateral meniscus is thicker than the medial meniscus. But the diameter, the medial one is wider than the lateral one. Can also compare their capsular attachments. So the medial meniscus is firmly attached to the joint capsule, while the lateral meniscus is not firmly attached to the joint capsule, it's loosely attached to the joint capsule. We can also compare the attachment with the collateral ligaments. We are going to talk about collateral ligaments shortly. Collateral ligaments are generally ligaments on either side of the joint. Now, the medial meniscus is related to medial collateral ligament, in which it is firmly attached to. The lateral meniscus is related to the lateral collateral ligament, but it's not firmly attached to it. It is actually separated from it by something else. Then we can compare their posterior attachments. So the attachments of the menisci are their posterior horns. Posteriorly, the medial meniscus has no ligamentous attachments. Or let me put it this way. We have what we call meniscofemoral ligaments that attach the posterior horn of the lateral meniscus. So from the meniscus to the femur, meniscofemoral. And these ligaments accompany what we call the posterior cruciate ligament. We're also going to talk about the posterior cruciate shortly. So the lateral meniscus has the anterior and posterior meniscofemoral ligaments attaching its posterior horn to the femur around the posterior cruciate ligaments. The medial meniscus does not have meniscofemoral ligaments attaching its posterior horn. Let's look at the mobility. The medial meniscus, because of its firm attachment to the capsule, is less mobile. When the knee is moving, the meniscus will also tend to be displaced a bit. But that displacement is not much for the medial meniscus compared to the lateral meniscus. So the lateral meniscus is displaced much during knee motion compared to the displacement degree of the medial meniscus during knee motion. How about susceptibility to injury? Because of its fixation, the medial meniscus is therefore more prone to being injured, being crushed, because it cannot displace, so it will be impacted by the force. But the lateral meniscus, because it can move, it is less commonly injured. If you look at how much the menisci cover the tibial plateau, we'd already mentioned this earlier, that the lateral meniscus covers much more of the tibial plateau compared to the medial meniscus. Last but not least is the functional emphasis. Yes, they have those functions that we've alluded to in the previous slide, but the medial meniscus is the one that is more for stability, and the lateral meniscus is the one that's predominant for load transmission and shock absorption. Or let me put it this way, that the medial meniscus does not perform much of load transmission and shock absorption, but the lateral one does. For a number of reasons. One, because of its size. So the diameter is shorter. That means that when femur rests on the meniscus, the one that is narrower will have a lot of force compared to the one that's wider. But also because of the femoral angulation. So because of femoral angulation, the weight of the body is more centered on the lateral condyle, femoral condyle, and lateral tibial condyle compared to the medial femoral condyle and medial tibial condyle. So force is transmitted more to the lateral than the medial. Great. Those are the key differences between the medial and the lateral knee meniscus. I want to show you MRI images of the menisci. So this structure with dark signal is the meniscus. That's the meniscus. And that's the meniscus as well. You can tell that this is the lateral meniscus because you can see this is fibula. So that's lateral meniscus, and that's medial meniscus. So this is coronal view. This other image is a sagittal view. So this is meniscus. Again, this lateral because this is fibula. So lateral meniscus, look at the distance, a bit short between the anterior horn and posterior horn. That's the lateral meniscus. Now we've moved from the lateral tibiofemoral articulation. That means we are going to the medial tibiofemoral articulation. And so we are seeing the medial meniscus. Look at the distance between the anterior and posterior horn, quite apart. I told about the diameter being much wider. So that is the anterior horn, posterior horn of the medial meniscus. This distance, that diameter is much more than the diameter that we saw for the lateral meniscus. Okay, something clinical about the menisci. We have what we call discoid meniscus. So a discoid meniscus is a meniscus that looks like the one you can see in those three images, that one and that one and that one. This commonly involved the lateral meniscus than the medial meniscus. You can see in this image, the medial meniscus is actually normally not all of them. But the lateral meniscus has this extension that goes all the way, covering more than 80% of the tibial plateau. So the danger of the discoid meniscus is it's being prone to injury because it means now it's being crushed in almost all phases of movement. It cannot displace. A discoid meniscus will not be that mobile because the weight of the body is directly on top of it. So it's like being trapped by femur and tibia. Great. We have done bony factor, but we've also talked about the contribution of the knee menisci. Let's look at the other static stability factor, which are the capsulo-ligamentous factors, so capsule and ligaments. The capsulo-ligamentous factor constitute the main stability factor of the knee joint because you just mentioned that bony configuration is not that much. So for the knee, ligaments is the thing. Unlike the hip, where bony configuration was the thing, the ball of the femur fits nicely into the socket of the acetabulum. But here, the ligaments are the ones that play the major role. Ligaments of a synovial joint can be classified as either intracapsular, capsular, or extracapsular. And the knee joint has all these types of ligaments actually. There are several ligaments which are present in the knee joints. They contribute to the stability of this joint, making this joint one of the most stable joints in the body, albeit the fact that the bony configuration is not that important. So let's talk about the ligaments. I'll start with intracapsular ligaments, the cruciate ligaments. So the cruciate ligaments are very strong intracapsular yet extrasynovial ligaments that crisscross within the joint, and that's what they're called cruciate. They crisscross. In terms of their origin and insertion, conventionally, we prefer to say that they arise from the tibia and insert onto the femur. However, because a number of people, some people are wired to think that origin has to be on the upper part and insertion lower part. So some people will then say that it arises from the femur and insert onto the tibia. If you don't like that type of ambiguity, You can talk about the proximal attachment and the distal attachments. So the proximal attachment are the femoral condyles, and the distal attachments are the tibia, specifically the tibial intercondylar area. Now, these ligaments are named based on their tibial origin. We have the anterior cruciate ligament that arises from the anterior intercondylar area. So that's why we call it anterior cruciate, because it arises from the anterior intercondylar area. This is the ACL. It arises from the anterior intercondylar area of the tibia. Where does it insert? Important to note is that it inserts onto the lateral femoral condyle. But I want to add some salt to that statement. So this ligament arises anteriorly from the anterior intercondylar area anteriorly. So it runs upwards and backwards. It runs upwards and backwards. And because it runs backwards, or rather, because it runs upwards, it will go to the femur. That one is straightforward. Because it runs backwards, it will then insert on the posterior aspects of the condyle rather than the anterior aspects of the femoral condyle. So it inserts on the posterior aspects of the lateral femoral condyle. Now, where exactly? Within the intercondylar notch. If you look at the lateral femoral condyle, the intercondylar notch is on its medial aspect. So it's on the medial aspect, or we can call it the internal aspect of the lateral femoral condyle posteriorly. That's where the ACL inserts. Because of that orientation, ACL prevents anterior displacement of the tibia. So basically, it prevents anterior dislocation of the knee joint. As an individual extends their knee joint, the ACL becomes tense. And for that reason, we can also say that the ACL prevents knee hyperextension. Extension of the knee is limited, by the way. From a neutral position, most people can only do maybe 5 to 10 degrees of extension from a neutral point. So not so much because of ACL. Another important thing is that the ACL initiates the mechanism of locking. We'll talk about locking shortly when we discuss movements of the knee. So it will initiate the mechanisms of locking. From a clinical perspective, ACL is usually attached to the medial meniscus, which is also attached to the capsule family, and also attached to what we call the medial collateral ligament. So what is an appetite? An appetite is simultaneous injury of three knee structures. We have the anterior cruciate ligaments, medial meniscus of the knee, and the medial collateral ligaments. The medial collateral ligament is also called the tibial collateral ligament. So the simultaneous injury of those three structures constitute the unhappy triad. Why do they tend to be injured simultaneously? Because they are attached. And the force that commonly injure them is a force that is making the knee joint to be forcefully abducted. We call that a valgus force. So a valgus force, a strong valgus force tends to injure these three structures together because of the attachment, because of the orientation. Now, for us to test whether the anterior cruciate ligament is intact clinically, we may do what we call the anterior drawer test. Anterior drawer test is a test done with the knee joint being 90 degrees flexed with the patient lying supine on the couch as shown in this particular image. So the patient lies supine first, then the knee is 90 degrees flexed here. So you can make here 45 and that 45 or roughly so. So what you do, we pull the leg anteriorly, like the way a drawer operates. So if this leg moves, in this position, it is believed that the ACL should be very tight at this position, not to allow anterior displacement. So if ACL can move anterior, if the leg can move anteriorly, it means that the ACL is most likely torn. Again, testing knee ligaments is a tricky thing because there are several ligaments. And so most likely when you test, you're testing 2 or more ligaments in the same test. But what we note is that with this particular position, the ligament that is optimal in its function and key is the ACL. And that is why if it's defective, this joint is likely to allow some anterior displacement in what we call the anterior drawer test. Similar concept will apply for posterior cruciate ligament. Posterior drawer test will be just pushing this leg backwards. And that will allow, if the posterior cruciate ligament is torn, it may allow the leg to move posteriorly. Let's talk about the PCL, posterior cruciate ligament. Again, called so because it arises from the posterior intercondylar area of the tibia there. So this ligament fans anteriorly and upwards. However, this ligament is more vertical compared to the ACL. So it runs more vertically than horizontally compared to ACL that runs, okay, it's more, if you look at the horizontal angulation of the two ligaments, the PCL is more vertical compared to the ACL. We are going to see that in some images I have for you. It's also much thicker and stronger than the ACL. This one inserts onto the medial femoral condyle. Of course, because it was still going anteriorly, it will still insert on the anterior aspect of the medial femoral condyle, but not so much because of what I've told you, its orientation is more vertical. In terms of its role, it will prevent posterior knee dislocation. That is to mean displacement of the tibia posteriorly relative to the femur. This ligament is important when you're walking downhill. When you're walking downhill on a fixed tibia, the femur tends to displace anteriorly. So remember, anterior translation of femur on the tibia is similar to posterior dislocation of the knee. So this ligament is important when you're walking downhill. There are 2 other ligaments associated with the posterior cruciate ligament. So these are the meniscofemoral ligament, and this is one of them. So that's the posterior meniscofemoral ligament. This is another one called anterior that runs in front of it. They both attach to the posterior horn of the lateral meniscus, and they insert together the PCL on the medial femoral condyle. This image shows you the posterior and the anterior meniscofemoral ligaments. They may have some names of people, as you can see in that image. So the anterior one is others called the Humphreys one, and the posterior one is others called the Wisberg one. These 2 images show you this magnificent ligament. So we see the ACL and the PCL. Even here we see the ACL and the PCL. We can see the way ACL arises from the anterior intercondylar area and go to the lateral femoral condyle. We can see the crisscross, so the PCL has now become anteriorly in as much as it originates posteriorly. We can also see that one here. PCL has now become anterior and it's inserting now on this condyle, as opposed to ACL that has gone posteriorly and it's inserting to this condyle, the latter one. Okay, now let's look at those two ligaments on these MRI images. So this is a sagittal one. We are still seeing the menisci there. And I hope you can now guess which menisci those are. But now this is the PCL. That's the posterior cruciate ligament, that dark signal. And then this is ACL, anterior cruciate ligament. Okay, we are moving to the other side. So that's meniscus. We confirm that's lateral meniscus. You can see the distance there. Back to the intercondylar area. So that's ACL from the anterior intercondylar area to the femur. And this is PCL from the posterior intercondylar area to the femur as well. The second image is a coronal image. So you may not be able to deduce much if you're not familiar with MRI anatomy of the knee, but we're looking at the intercondylar notch and we'll pick something. So these dark signals, these are the cruciate ligaments. Okay, let's pick one. So this is the ACL up to the attachment. And this is PCL up to its attachment. So that's PCL, you can see there. Just follow the dark signal. That's PCL. And this one is ACL. Let's state some differences between ACL and PCL. So the ACL origin, or what I can call the distal attachment, is the anterior intercondylar area, as opposed to PCL, whose origin is the posterior intercondylar area. In terms of insertion, which is the proximal attachment, so ACL inserts into the lateral femoral condyle. Remember, the posterior aspect of the lateral femoral condyle medially. PCL inserts onto the medial femoral condyle. Again, remember, anterior aspects of the medial femoral condyle laterally. In terms of their roles, ACL has unique functions compared to the PCL. So ACL prevents anterior translation of tibia on the femur, while PCL prevents posterior translation of tibia on femur. ACL limits hyperextension, while PCL limits hyperflexion, but I put that in asterisk because the main thing that limits hyperflexion is actually when the leg, the calf, comes into contact with the thigh. That's the main fact that limits knee hyperflexion. But the ligament also has some role anyway because it becomes tight in full flexion. Other role for the ACL compared to PCL, that ACL provides rotational stability, especially limiting internal rotation, and this is also based on its orientation. The PCL provides central pivotal stability during knee motion. So generally, it's the one that holds the structures in place in the knee motion. Remember, it was relatively vertical, so it's very central. And so it offered that central stability. In terms of clinical aspects, a number of things to mention. ACL is the one that is commonly injured. So PCL is not commonly injured, but ACL is. And in terms of the mechanisms that cause the injury, Um, for ACL, you'll injure it more in sports, twisting, sudden stops, those abrupt valgus stresses on the knee. While PCL will tend to be injured, maybe in dashboard injury. Dashboard injuries are injuries that occur when the knee is in flexion and somebody knocks the knee or the tibia, as typical when happens in car accidents. That's what they're called, dashboard injuries. So that's the kind of injury that's likely to injure PCL, but for ACL, maybe sports, twisting, things like that. Commonly associated injury for ACL is the anapital that I've already talked about, simultaneous injury of ACL, medial meniscus, and medial collateral ligament. We do not have these associations for PCL. The clinical test for checking the integrity of ACL are those three. I've already elaborated on the anterior drawer test. A similar thing with different direction for the PCL, posterior drawer test. You can check what is Lachman test. You can check on what is pivot shift test. You can check on what is posterior sag sign. At least remember anterior drawer test for ACL and posterior drawer test for PCL. In terms of healing, ACL usually does not have very good healing, and so it often requires surgical reconstruction if it's torn. PCL, most of the time, will heal conservatively, may not require surgery for healing. All right, so those are the cruciate ligaments. They're intracapsular. Now let's talk about the collateral ligaments of the knee. Again, there are only two, but we'll still spend time. The collateral ligaments are essential in offering side-to-side stability. So these are the collateral ligaments. They're on either side. Because of their presence, the knee does not experience adduction and abduction movements. Whenever there's a collateral ligament, you change that joint to be a hinge so that you abolish the adduction, abduction movements. We cannot move in the coronal plane. We only allow movement in the sagittal plane. There are two ligaments, the medial collateral ligament, MCL, also known as tibial collateral ligament, because it's on the tibial side, or we can say because it attaches on the tibia. The medial collateral ligament, MCL or TCL, is a very broad ligament, and it's also attached to the capsule. So it's a capsular ligament. This ligament has superficial and deep parts. The superficial parts will run from the femur all the way to the tibia like that. But the deep parts are also from femur, but they make contact with the medial meniscus, and then from the medial meniscus to the tibia as well. So the edges of the articular surfaces and the meniscus, and that's very key. Remember, it's part of the capsule. So it's a capsular ligament. This is the superficial part of MCL, very broad ligament, as you can see. The deep parts are not very clean from this image, so you may not figure out that much, but at least the superficial part you can see. Now, based on its location and position, the medial collateral ligament is the primary stabilizer against valgus stress. So what is valgus stress? I had mentioned it earlier. Valgus stress is a force that is pushing the knee inward so that to force it to go into abduction. Like in this image here, so the second one down there, if you push the knee from the outside, So that means you're pushing it inwards. You are making this side to gap so that the leg can go outwards, basically. So you are forcing this joint to go into abduction. That is valgus stress. The MCL is the primary stabilizer against valgus stress. I'd already mentioned that valgus forces tend to injure this ligament, therefore, together with other two structures in what we call the anapic triad. The lateral collateral ligament is cord-like. This is the LCL. We can also call it fibular collateral ligament because it attaches the fibula. So it arises from the femur and goes to the head of fibula. Important to remember that because the medial collateral was arising from the middle femoral epicondyle, but goes to the tibia. The fibular collateral ligament arises from the lateral femoral condyle and goes to the head of fibula. This is where it attaches together the biceps femoris muscle. So it's cord-like and it is extracapsular. You can see there's a gap between the ligaments and the joint. Is the primary stabilizer against varus stress. So varus stress is a force that is making this joint to go into adduction. This is what I mean. So if you have a valgus stressing force, it's making this joint to go into abduction. It will force the medial collateral ligament to function or to tear. Varus force is a force that's making this joint to go into adduction. So basically, the leg moving inwards because the joint is gaping on the lateral aspect. So the LCL, lateral collateral ligament, is the one that's being forced to act or to snap. This is MRI image of the knee. I want to show you the ligaments. Okay, so we can see the collateral ligament. So this is the medial collateral ligament. Okay, it's gone. Let's wait for it. So this is the medial collateral ligament, very thick and attached to the meniscus. Compare that with the lateral collateral ligament, which is this one here. So take note that it's extracapsular. We can see some gap between the ligaments and the meniscus. The middle, on the other hand, it's very thick and attached to the capsule as well as the meniscus. You can see that's the medial meniscus. This is the ligament. You can't even separate the ligament from the meniscus from the capsule. Some differences between MCL and LCL. So in terms of their origins, attachments, or rather, so the origin, so here proximal mean origin, not a big deal. MCL arises from the medial femoral epicondyle, while the LCL arises from the lateral femoral epicondyle. We go to the insertion. MCL inserts into the medial tibial condyle and shaft. It's an expansive insertion, while LCL inserts the head of fibula. Very key difference. In terms of other attachments, remember that MCL is attached to the medial meniscus, while this one is not attached to the medial meniscus. Mentioned to you that MCL is capsular, while LCL is extracapsular. So it's not attached to the capsule, it's actually separated from the meniscus by the tendon of popliteus muscle. In terms of their role, MCL offers medial stability, while LCL offers lateral stability. MCL, so medial stability means that displacement medially, basically. MCL resists forces that force abduction, that's the valgus stress, while LCL resists forces that force abduction, that is varus stress. MCL limits anterior tibial translation together with ACL, and this is also based on its orientation. It's not very vertical, by the way. It is slanting anteriorly from up downwards. And so it has that oblique orientation, which means that it can also prevent anterior translation of the tibia on the femur. Based on its orientation, the LCL helps to limit excess external rotation of the tibia. In terms of clinical aspects, so the MCL is the one that is more commonly injured compared to LCL. MCL injury would be often caused by valgus forces that will injure together the medial meniscus. If you compare the forces that injure LCL, there'll be more of the varus forces, and this will not involve the medial meniscus, but will involve the structures at the posterolateral corner of the knee. So what are these structures at the posterolateral corner of the knee? Maybe one that is easy to mention at this point in time is the biceps tendon. So it could also be involved in the injury of LCL. In terms of clinical tests, we just do the stress test. We have what we call the valgus stress test and varus stress test. I'd already shown you those ones in the previous image. In terms of healing, now MCL typically heals very well because of its good blood supply. It has a rich blood supply, so healing is good compared to LCL that may require surgery, especially if other ligaments are also involved in the injury, because it does not have good healing. All right. Now we have talked about major ligaments, but let's also talk about the capsular factors and the other capsular ligaments. So the knee joint capsule is fibrous membrane, just like any other capsule of a synovial joint, but important is that it is thick and its thickness also varies. There are also other capsular ligaments that are within it. We have already talked about the medial collateral ligaments. I'll not repeat about it. The capsule of the knee attaches onto the articulating structures. The key capsular ligaments are the patellar tendon. Again, I'd already mentioned that this could be considered as a ligament or as a tendon, so we can still include it here because of stability factor. Attaching the patella to the tibia tuberosity. We have the medial and lateral patellar retinaculum. So in this image, we can see some fibers attaching the patella laterally and medially. We call this the medial and the lateral patellar retinaculum. They are part of the capsule, but they are fibers of the capsule that run in those directions, anchoring the patella on either side. Remember, the patella has natural predisposition to be dislocated laterally. For that reason, the medial patellar retinaculum is more prominent, more strong to hold the patella in place. Having three different bands, as you can see there. So we have some fibers that come from the patella to the femur. We have some fibers that come from the patella to the meniscus. We have some fibers that come from the patella all the way to the tibia. So they all constitute part of the part of the medial patellar retinacular fibers, anchoring the patella to prevent its lateral tendency of dislocation. The medial collateral ligament we already talked about is one of the capsular ligaments. As you can see it there, so I don't need to repeat much about it. The oblique popliteal ligament is this ligament here. It's a posterior thickening, posterior reinforcement of the capsule. The oblique popliteal ligament are fibers that expand from the insertion of semimembranosus muscle. So from the expansion of semimembranosus muscle, we have those fibers that constitute the oblique popliteal ligament, reinforcing the posterior capsule. Then we have the arcuate popliteal ligament. The arcuate popliteal ligament arises from the head of fibula and cross and reinforce also the posterior capsule, but allowing the passage of the popliteus muscle. The popliteus muscle goes intracapsular. So as it goes, this is the part that it uses to go intracapsular. All right, so those are the ligaments, capsular ligaments. This image I'll use to demonstrate the patellar tendon. So this is the quadriceps tendon. This is the patella. That's the patellar tendon. Okay, let's wait for it. It's scanned to the other side. So this is the lateral side. You can see the mid-lateral meniscus there. So that's quadriceps tendon. This is patella, this patellar tendon, and that's tibiotuberosity insertion. So this is the joint. The joint is within here. We can also see the cruciates, like that's PCL, and that's ACL. And these are the meniscus. So the lateral meniscus, we can see the head of fibula there. Okay, we can now talk about the dynamic stability factors of the knee. So the dynamic stability factors consist of muscles, their tendons, muscles and their tendons. There are several muscles or their tendons that cross the knee joint, and that means that they definitely contribute to the stability of the knee given. But we have some key dynamic stabilizers that I want to mention. Quadriceps, especially the vastus medialis obliquus that I mentioned earlier, the popliteus muscle and its tendon. We have the hamstring group of muscles. We have the gastrocnemic group of muscles. We have the pes anteriorus group of muscles, and you have the iliotibial band. Let's say something about each of those. So vastus medialis obliquus are the lower fibers of vastus medialis muscle. What we know about these fibers is that they insert onto the medial aspect of the patella. And that means that when the quadriceps is pulling, these fibers also pull the patella medially, preventing its lateral displacement. How about the hamstring group of muscles? So remember how the hamstrings come? Semitendinosus and semimembranosus go medially, then biceps goes laterally. So they both go to the joint, one on the medial side, okay, two on the medial side and one on the lateral side. But remember, this one on the lateral side is biceps long head, but they also have a short head. So the force is almost an equal force on either side, relatively stabilizing that joint in a sense. Because of those muscles, the anterior tibial translation is limited. So they assist the ACL. At flexion, they also control the rotation. They're the same muscles that will cause rotation. But remember, when one acts to rotate, the other one will limit how much that rotation can happen, and vice versa. So they control rotation of the knee joint. The oblique popliteal ligaments, extension of semimembranosus, is also important in reinforcing the posterior capsule of the knee joints. How about popliteus muscle and its tendon? So the popliteus muscle is a very interesting muscle. It causes what we call unlocking of the knee joint. Usually when the joint moves towards the end of extension, the femur rotates suddenly medially on the tibia, on a fixed tibia. Or we can say that the tibia rotates suddenly laterally if it was free. That sudden medial rotation of the femur on a fixed tibia towards the end of extension is what's called locking. The joint screws home so that the lower limb becomes one rigid column that can now bear weight with minimal muscular activity. To come from a fully extended knee, then the joint needs to unlock first. And so that's the role of popliteus. It now screws it so that it's not one rigid column before now movement can occur. Otherwise, if you didn't unlock and you force movement, you can actually injure or cause strain to a lot of ligaments. Other than that, the popliteus muscle also controls the posterolateral stability of the joint because the muscle is on that side, and generally prevents excess external tibial rotation because of its orientation. So it prevents excess tibial rotation. Gastrocnemic group, remember we have medial and lateral head. They're also responsible for posterior stability. So they anchor from posterior. Again, just like the hamstring, they're in two columns, medial and lateral, with almost equal force. So again, balancing the forces posteriorly. Together with the posterior cruciate ligament, the gastrocnemial muscles actually resist posterior tibial translation. The pes anserinus group, also known as the gyropes, consists of three long muscles: sartorius, semitendinosus, and the gracilis muscle. They insert together in a common aponeurosis that we call the anserinus, the pes anserinus. And there's even a bursa related with the same name. So these three, the pes anserinus group, provide medial stability to the joint, and they also help in resisting valgus stress, assisting the medial collateral ligament. Iliotibial band is an insertion of two big muscles. We have the gluteus maximus muscle, generally the upper three-quarter fibers, and we have the tensor fascia lata. So their insertion through iliotibial band is also very key. The iliotibial band extends all the way to insert into the tibia and the lateral condyle of tibia. Its presence is important in helping to provide lateral stability, also resisting varus force, just together with the LCL, and also helping controlling knee during its flexion extension movement, stabilizes the knee during extension flexion movements. All right, so those are the dynamic stabilizers of the knee. And that's very, very helpful. We have finished the stability factor of the knee. I know that was really intense and a lot, but that is the knee. The remaining aspects are very quick, so I'll move very fast into them. Relational anatomy of the knee joint. So the knee is surrounded importantly by the structures within the popliteal fossa. So in as much as we know that we can also have great saphenous vein somewhere, saphenous nerve somewhere, the most important relation anatomy of the knee are the contents of the popliteal fossa. So that means posterior relations of the knee. So I'll not spend much time on that because you know the contents of the popliteal fossa, and so you know what is posterior. We can go to the neurovascular supply of the knee. So the neurovascular supply of the knee, starting with the arterial blood supply. The knee is surrounded by several arteries. Several arteries anastomose around the knee to constitute what we call the genicular anastomosis. So the genicular anastomosis consists of several arteries. We can start with the branches of the popliteal artery: superior medial genicular, inferior medial genicular, superior lateral genicular, inferior lateral genicular artery. Those four branches of the popliteal artery contribute to the genicular anastomosis. There's another branch of the popliteal artery, that's the middle genicular arteries. The middle genicular arteries are known not to participate in the anastomosis, but still to supply the knee, because these vessels go inside. So they supply the intra-articular structures, like the cruciate ligaments, are the ones being supplied by the middle genicular arteries. So because of that, they do not participate much in the anastomosis, but they still supply the knee. So that's still important to be mentioned in vascular supply to the knee, but we don't talk about them much in the genicular anastomosis. Other than branches of popliteal artery, which are now, we've mentioned 4 or 5, depending on how you want to look at it, the other arteries that also contribute to the genicular anastomosis are the following. We have the descending branch of the lateral circumflex femoral artery. We have the descending genicular artery, which is a branch of the superficial femoral artery just before superficial femoral artery disappears through the adductor hiatus. So this descending genicular artery does not go through the adductor hiatus. It doesn't run with the popliteal artery. It is given before the artery disappears through the hiatus to become the popliteal artery. Lower down, we have branches that arise from the anterior tibial artery, which go back, so correctly called the recurrent arteries. Okay, so there are several arteries that participate in the genicular anastomosis, so to speak. For the nerves, remember Hilton's law. That still applies even for knee. The nerve supply to a joint will generally follow the nerve supply to the muscles that cross and therefore act on that particular joint. So that means we've also summarized the innervation of the knee. All the nerves you can think about that are around here, most likely also gives you supply to the joint. But some to mention in particular, we have specific articular branches. So tibial nerve gives you the superior lateral genicular nerve. Sorry, the common peroneal nerve gives you two genicular nerves, the superior lateral genicular nerve and the inferior lateral genicular nerve. Those ones come from the common peroneal nerve. Before the common peroneal nerve divides into two, it also gives you one last nerve that also supplies the superior tibiofibular articulation, and that's the recurrent peroneal nerve or the recurrent fibular nerve. You can call it the recurrent genicular nerve. So those two are given the popliteal fossa. The last one is given outside the popliteal fossa, but that's still articular branch to the knee. Tibial nerve, on the other hand, gives you those genicular nerves that have M with them in their name. So superior medial genicular, inferior medial genicular, and middle genicular nerves as well. So those are genicular nerves, specific articular nerves that go to the knee. We remember that we also have, from our discussion from the anteromedial thigh, remember that obturator also gives you some articular branches to the knee. And because of that, you can actually have pain referral from the knee being felt at the hip because of common innervation by the obturator nerve as a clinical concept you need to remember. Let's finish with the mobility. So the knee, as we've already agreed, is a modified hinge joint, predominantly allowing flexion and extension movements. But we've also mentioned that at mid-flexion, the knee can allow some rotation movements. So, which are the primary muscles that will extend the knee? So this is basically what we call the extensor apparatus of the knee joint, consisting of 5 things. 1, the quadriceps femoris unit. 2, the quadriceps tendon. 3, the patella. 4, the patellar tendon. And 5, tibial tuberosity. So those 5 constitute the extensor apparatus of the knee. Of course, the force is generated by the quadriceps femoris unit, which consists of 4 muscles. But all those 5 elements need to be present for knee extension to occur. The muscles that cause flexion are many. So primarily, we can talk about the hamstring group of muscles. If you use the term hamstring, we get lost in how then to classify the short head of biceps. But remember, muscle of the posterior thigh will basically flex the knee. The gastrocnemi also flex the knee. Other than that, sartorius also flexes the knee. So there are many muscles that can actually flex the knee. Popliteus also flexes the knee. How about rotation? So the muscles on the lateral aspect will tend to cause lateral rotation. So things like biceps will cause lateral rotation. Remember, at mid flexion. And then muscles like gracilis, sartorius, semitendinosus, semimembranosus will cause medial rotation because they're on the medial aspect. Remember, again, the knee need to be at mid flexion for those rotation movement to occur. Now, we can look at knee rotation in 3 ways. The first one is what I've just told you. Those rotatory movements of the tibia at mid-flexion caused by those muscles. But there are also other 2 aspects of knee medial rotation, or rather rotatory movements at the knee that we need to understand. So we have rotatory movements that occur in the course of flexion and extension, and they're obligatory. They're inevitable. You do not have control over them. Why is that so? We are going to see that shortly. And then we have other rotatory movements that occur at the end of extension or at the beginning of flexion from full extension, which we call locking and unlocking. Those are rotatory movements. So let's explain them. I want you to look at this surface of the tibia that receives the femur, and let's go slowly here as we finish. So this is the lateral meniscus on the lateral tibial condyle. This is the medial meniscus on the medial femoral condyle. The femur is supposed to rest on top of this part. We mentioned earlier the anteroposterior distance from here to here for the tibia is shorter than the corresponding one for femur. Similar thing we can say about this side. The anteroposterior distance from here to here is shorter than the corresponding femoral medial condyle. What does that mean? So going slowly, if you are coming from full flexion, it means that the femur must roll forwards but slide backwards so that the whole length of the femoral articulating surface can be accommodated on the short dimension of the tibia. Let me use this mouse to illustrate that again. So if this is okay, where can you see it nicely? Okay, let's try that one. So if this is the femoral receiving end, and the tibia receiving end is just that short, it means that femur must roll forward but slide back so that the whole length can be accommodated within the short anterior-posterior distance of the tibia. So again, I'll show you this one. Okay, I'm trying to orient that with my camera. So if the whole of that is the surface of the tibia, sorry, of the femur, and maybe just from here to there is the surface of the tibia. So femur must roll forwards and slide backwards. Roll forward and slide backwards during extension, or the reverse during flexion. So it's easier for me to just discuss one of them. So let me just limit myself to extending from full flexion. Femur rolls forward and slides backwards on the tibial plateau. So I'm hoping that that point is clear, that inevitably femur must roll forward and slide backwards. Now let's upgrade that information. The tibial receiving ends have meniscus each. Lateral meniscus having a shorter diameter compared to the medial meniscus. That means that the receiving ends have curvatures which have different radius. I'm allowing that to sink. The lateral meniscal surface will appear to be much deeper because of the short distance of the two horns of the lateral meniscus compared to this side. So this one will offer a shallower surface compared to this side. So this is much curved. This side is much curved compared to this side that is less curved, just because of how you place the menisci. So if you have understood that, let's revisit the former statement of rolling forward and sliding backwards. And let's debate on the sliding backwards. So if the femur is going to slide backwards, and we are saying that the receiving ends here are different in terms of how shallow or flat they are. The sliding backwards or the sliding will be more on the shallower side than on the deeper side. Please allow that to sink again. So if somebody is extending from a flex position, the lateral femoral condyle will roll forward and slide backwards. The medial femoral condyle will also slide, or rather roll forwards and slide backwards. But the medial femoral condyle will be sliding backwards more than the lateral femoral condyle. It will be sliding backwards more. As the femur is sliding backwards more on this side compared to this side, it means that the femur is rotating on a fixed tibia. So that is an inevitable medial rotation of the femur on a fixed tibia. Again, don't allow the language to confuse you. Remember, the natural movement of any joint is that the distal aspect, the distal segment is the one that moves. When we say that the knee is flexed, it's actually the leg that is actually moving. When you say that the hip is flexing, it's actually the thigh that's actually moving. But I'm qualifying my statement by saying that the femur is the one moving on a fixed tibia. So get that right. Because if the femur is moving on a fixed tibia and is actually rotating medially, because you are saying that the posterior translation, the sliding backwards, is more on the medial side than on the lateral side. It means that the femur is rotating medially on a fixed tibia. That, if it was to be said in a different language without qualifying which segment is moving, it will be said it's a lateral rotation of the knee joint. So medial rotation of femur on a fixed tibia is actually lateral rotation of the knee joints, because it means that if you are to consider the femur to be the one that is fixed, then it's the tibia that's moving laterally. I hope that has sunk. So back to this statement. What I've described to you is actually point number 2. That when this joint is extending from a flexed, fully flexed position, the femur must roll forwards and slide backwards. This sliding backwards, posterior translation of the femur on a fixed tibia, occurs more on the medial condyle of femur than lateral condyle of femur. And that makes it that the femur is rotating medially on a fixed tibia. That medial rotation is inevitable, it's obligatory, it's part and parcel of extension. And the reverse will also happen if this joint was to be flexing from an extended position. Now let's come back to this last one. As the knee joint extends, the anterior cruciate ligament becomes tight and tight. It reaches a point towards the end of extension that the ACL is taut. Once it becomes tight, it means it cannot allow any further posterior translation of the femur. Again, allow that to sink. Now remember, ACL attaches on the lateral femoral condyle. What does that mean? It means that towards the end of extension, full extension, it reaches a point when the lateral femoral condyle can no longer slide backwards because it's been fixed by ACL. But that does not apply to the medial femoral condyle. The medial femoral condyle can still move because it's not limited. And so this is what we see happening towards the end of extension. The ACL becomes tight, it fixes the lateral femoral condyle so that lateral femoral condyle can no longer translate backwards, allowing only the medial femoral condyle to translate backwards. That translation of the medial femoral condyle at the end of extension with an ACL that is tight, and so the lateral femoral condyle cannot translate backward, is what we call locking. It is an abrupt medial rotation of the femur at the end of extension. That medial rotation of the femur on a fixed tibia at the end of extension makes the joint to be screwed home. A locked knee, a screwed home knee, is a fully extended knee with all the ligaments tight for some reason, by the way. All the ligaments become tight at that point. And why is that important? We know that the knee joint is important for bearing weight, the body. But we know that the weight of the body can be depending on your weight. But generally, you can figure that out. It's a lot. Now, if you are to make that weight, if you are to stand for long, you need something that will bear that weight with minimal muscular activity. So the locking of the knee makes the lower limb be one rigid column that can support the weight of the body with minimal muscular activity. So minimal quadriceps activity, minimal hamstring activity. We just want to conserve energy, especially if you're going to stand for long. You can try it by standing with your knee flexed and see how long you can actually stand. When you're standing with muscular activities, it takes a lot of energy, you get tired. But if the knee is locked, so we are relieving muscles, not totally, but at least minimal. We are relieving muscles and now relying on force transmission on bone and ligaments. That's the purpose of locking. So that abrupt medial rotation towards the end of extension caused by an ACL that is tight, fixing the lateral femoral condyle so that lateral femoral condyle cannot translate backwards, allowing only the medial femoral condyle to translate backward is what we call locking. For us to come from that position, if you want to initiate flexion, then popliteus must act. Popliteus now contracts to cause lateral rotation of the femur on a fixed tibia. Again, I'm qualifying because if you leave it that way, then we'll say actually popliteus causes medial rotation of the knee. But we are saying popliteus causes lateral rotation of the femur on a fixed tibia, and that is what we call unlocking of the knee before the rest of the flexion process can go on. Great, so that is it with the movements of the knee, and that summarizes the whole story of the anatomy of the knee. Just to finish with something around the bursae of the knee. I'm bringing this here because the bursae are related to the various tendons. So there are several bursae around the knee joints. We can classify them based on where they are found. The ones I've highlighted in green have some clinical reasons that I want to highlight. But let's talk about the anterior bursae. 4 main bursae present. The suprapatellar bursa is located between the quadriceps tendon and the femur. It's actually the largest bursa of the knee, and this bursa is continuous with the joint cavity. So how is that clinically important? If you have infection here or effusion here, that fluid will also go there, which means if you want to get some fluid from the joint, you may not need to prick here. You can actually just prick there and get the fluid. But also means that any infection here can also reach the joint. To prevent this bursa from being crushed, there's also another muscle here that usually pulls it. When the quadriceps is acting, we call that articularis genu. So it usually pulls the bursa upwards when the knee is extending so that this bursa is not crushed by the patella during extension. Articularis genu. How about the prepatellar bursa? The prepatellar bursa is here between the patella and the skin. That's the prepatellar bursa. The inflammation of the prepatellar bursa is otherwise known as housemaid's knee. Why is that so? Okay, so imagine somebody who is cleaning, mopping the floor, maybe under the bed. So they have to be almost horizontal on the floor, kneeling. So the part of the knee that makes contact with the floor is actually the patella. So this is the bursa that will be crushed, so to speak, in those kind of kneeling. The housemates is the one that tends to do this a lot, and so that's why it's called the housemate's knee. Let me talk about the superficial infrapatellar first. So the superficial infrapatellar bursa is this one, the bursa between tibial tuberosity and the skin. So this is the one we call clergyman's knee. If it is inflamed, why we call it so is because the clergy tend to kneel with their tibial tuberosity down. The part of the knee that makes contact with the ground when they're praying is not the patella, but the tibial tuberosity. You can try that one, even if you were not fond of praying. Just try to kneel. Imagine somebody how they usually pray, or if you do, fine. You can try that and see that this is the part of the knee that makes contact with the ground. So inflammation of the superficial or subcutaneous infrapatellar bursa, we can call it subcutaneous or superficial. Inflammation subcutaneous infrapatellar bursa is called clergyman's knee. Between the quadriceps tendon and tibia, we have the deep infrapatellar bursa as one of the anterior bursae as well. Now, on the medial side, the medial bursae, we have the bursa related to the medial head of gastrocnemius, which also extends to also abut semitendinosus tendon, and sometimes may also abut the medial femoral condyle and the fibrous capsule. It's a complex bursa. That complex bursa usually communicates with the knee joint as well. And so when the synovial membrane of the knee is inflamed, sometimes it can pop out through that bursa and causes us to have a swelling in the popliteal fossa, what we call Baker cyst. So Baker cyst is a swelling of the popliteal fossa as a result of inflammation of the synovial membrane of the knee that pops through the bursa related to the medial head of gastrocnemius and semimembranosus bursa. Then we have the bursa related to the pes anserina and the medial collateral ligament. We can just call it the pes anserinus bursa. So pes anserinus bursa is the bursa that's commonly inflamed in athletes and footballers because they use a lot of these muscles as well. And so this is the bursa that usually commonly inflamed, causing painful knee. All right. The posterolateral bursae are also highlighted there. I don't want to mention anything clinical about them, but just know that we still have bursae between the lateral head of gastrocnemius and the joint capsule. And these one often communicate with the joint as well. We also have bursa related to the fibular collateral ligament and the tendon of biceps femoris. Another one between fibular collateral ligament and tendon popliteus and lateral femoral condyle. That may also communicate. All right, so those are the bursae around the knee. Remember, bursae reduce friction, basically. This shows you the Baker cyst concept that I told you. So inflammation of the synovial membrane of the knee can pop out through the bursa in the posterior aspect, and that's what we call Baker cyst. It's a cause of swelling in the popliteal fossa. So that brings me to the end. I'd already mentioned to you that the clinical aspects I'll incorporate, and sure enough, I've done that in the first 7 where applicable. So we will stop there. That will be the end of that very long lecture on the topographic anatomy of the knee. I hope you're now well informed about the knee. Our next session on topographic anatomy of the lower limb will be topographic anatomy of the leg. Thank you very much. We'll stop there.